Okay, so for our presentation, it is titled Born into Addiction. I am Holly Benight.
I am Becca Schmiel.
I'm Jasmine Irving.
And I'm Emily.
So to start off here, we just wanted to give you an introduction into what we chose and the issues associated. So the problem that we're looking at is infants born into addiction due to mother's substance use during and throughout pregnancy. So those associated issues are neonatal abstinence syndrome, or NAS, which we will definitely go into deeper later, direct and non-direct side effects for both mother and infant, as well as the costs associated with treatment and hospitalization. And then we're going to go into treatments, interventions, etc. But this just gives you a nice overview of the problem and the issues associated. So to dive right in, neonatal abstinence syndrome, or NAS, is a withdrawal syndrome that occurs in infants who are exposed to opioids in utero. The syndrome is characterized by tremors, irritability, poor feeding, respiratory distress, and seizures, all of which develop shortly after birth because of that withdrawal from the opioid. So the term NAS has been principally used to describe neonatal symptoms occurring after in utero exposure to opioids such as heroin, methadone, and use or misuse of prescription opioid-containing medications such as hydrocodone or Vicodin, or oxycodone or Oxycontin. However, I think it's important to note that other substances may generate these neurobehavioral dysregulations in the neonatal period consistent with an abstinence syndrome. These include alcohol, benzodiazepines, nicotine, and psychiatric medications such as antidepressants or antipsychotics. Exposures such as cocaine, nicotine, SRIs, and polydrugs can also potentiate the infant's expression of the opioid-induced NAS. So from here, Emily is going to take you into the next issue.
Okay, so now we're going to talk about some direct and non-direct effects of this syndrome. So drug use during pregnancy can have detrimental effects both directly and indirectly on the perinatal outcome. So some direct effects include fetal growth retardation resulting in small infants and a decreased head circumference. Further effects include facial dysmorphology and organ system anomalies such as alcohol-related birth defects. Indirectly, mothers abusing drugs are at an increased risk for preterm labor, thereby placing an already compromised fetus at an increased risk. The number of mothers and infants being infected by the human immunodeficiency virus from sharing needles, multiple sexual contacts, and mother-to-infant transmission is also increasing at an alarming rate. So from that, we are now going to talk about some costs associated with NAS. So infants with NAS have longer hospital stays, higher rates of readmission, and are more likely than non-opioid exposed newborns to require care in the NICU for management of their symptoms. So the number of Medicaid financed births that are impacted by NAS have risen substantially and totaled $462 million in hospital costs in 2014. And by 2016, this rose to $572.7 million in total costs. So improving affordable health insurance coverage for low-income women before pregnancy would expand access to substance use disorder treatment and could reduce NAS-related morbidity and costs. So newborns with NAS were hospitalized on average of 15.9 days, costing an average of $22,550 per infant in 2016. Back in 2004, 1.6% of hospital costs for birth covered by Medicaid were for the births of infants with NAS. And by 2014, NAS accounted for 6.7% of all birth-related hospital costs among infants who were covered by Medicaid. And again, in 2016, Medicaid was responsible for 83% of charges for in-hospital births with an NAS diagnosis, indicating that state and federal budgets may continue to bear disproportionate costs as the opioid crisis evolves. So just some figures associated with NAS. So the image on the left indicates the total hospital costs for NAS among infants who were enrolled in Medicaid. So as you can see, there's a very drastic yet steady increase from 2004 to 2014. And the image on the right indicates the proportion of birth-related hospital costs due to NAS among infants who were enrolled in Medicaid. So again, very steady yet drastic increase from 2004 to 2014.
So before we go into the interventions and treatments, I want to talk briefly about the scoring system used for NAS. So the most common and most popular scoring system used is the Finnegan scoring system. And this scoring system helps determine one, which neonates require pharmacological therapy, two, how dosing should be escalated, and then three, when the weaning should occur. So the traditional Finnegan scoring system consists of a 31-item scale used to assess the presence and the severity of various NAS-associated symptoms, and it's typically performed every 3 to 4 hours. But when given this evaluation, it should also be taken into account the behavior observed over the entire 3 to 4 hour period leading up to the assessment. And typically a scale, using the scale, the score of anything higher than 8 is pretty highly suggestive of NAS, even if in those denying opioid use during pregnancy. And that would indicate whether or not the infant should use pharmacological treatment.
Overall objectives of any of these interventions and treatments is to ensure that the infant is comfortable and safe, and we do that by preventing and alleviating withdrawal symptoms. We also want to get the infant back to normal functioning again, which includes sleeping, feeding and digestion, weight gain, etc., to support healthy development. Infants with NAS, they may show impaired feeding behaviors like excessive non-nutritive sucking, poor feeding, regurgitation, and diarrhea, which makes weight gain and nutrition challenging for this group. Opioid exposed infants have more feeding problems, like rejecting the nipple, spitting up, coughing, in comparison to non-drug exposed infants. The overall goals of the interventions include providing a safe, effective, and individualized care, avoiding complications of bodily systems, maintaining adequate infant nutrition, like I mentioned, and promoting maternal and parent-infant bonding. We'll go into these a little bit more. There's 2 different types, pharmacological and non-pharmacological, which is Jasmine kind of briefly mentioned. An effective intervention plan will usually involve interprofessional team members, so those specializing in nursing, social work, pharmacy, etc. There's some newer interventions as well that are not as widely used, like music therapy, massage, water beds, and volunteers for cuddlers. And most interventions usually incorporate support for the family as well.
So kind of going more into detail and piggybacking off what Becca was saying. So one of the types of treatment process is the non-pharmacological treatment. And typically the non-pharmacological treatment is the primary approach that we want to take. And it's used to comfort measures to decrease the severity of symptoms and mitigate the negative neonatal outcomes. This type of intervention has been shown to reduce the effects of withdrawal and should be implemented as soon as possible following the birth. So again, going back to the Finnegan score, any score that's less than 8 should be managed solely by using non-pharmacological approaches. Many NAS symptoms cause overstimulation in newborn infants, and using this type of approach utilizes the environmental and behavioral approaches to maximize infant comfort. So some examples would be environmental control. So that might include a quiet and dimly lit room, swaddling, positioning, and bed types such as like the water bed that Becca mentioned. Feeding methods such as breastfeeding would delay the onset and decreases the severity of withdrawal symptoms. And then also utilizing the social integration. So making a parental presence. So having both the baby and mom in the same room, and then also maximizing that skin-to-skin contact.
Okay. So another non-pharmacological approach. Mothers participating in opioid treatment programs are encouraged to breastfeed. Kind of like Jasmine was mentioning, there's tons of benefits with breastfeeding. As providing optimal nutrition, it promotes bonding and empowers the baby's mothers to be effective parents, as well as all the nutritional benefits from it. Specific criteria are given to healthcare providers to determine if breastfeeding a baby with NAS is safe. This includes with women's consent, whether they disclose postpartum plans for addictions counseling and their progress in treatment, a negative toxicology test at delivery, and they must be receiving must have received consistent prenatal care and have a counselor endorse achievement and maintenance of sobriety plan before and after delivery. There are women that are discouraged from breastfeeding. These would be the women who did not have prenatal care and women who have relapsed or who refused substance abuse treatment. Like we just said, there's tons of benefits for breastfeeding, but it's not safe for every infant, and including those with chemically dependent mothers at the time.
So then kind of going on the other spectrum, the pharmacological therapy is indicated for infants whose withdrawal signs are increasingly severe or whose concurrent NAS scores climb despite supportive measures to reduce and manage those symptoms. So again, the Finnegan score that is above 8, this would be the type of approach for those infants. And in addition, infants who require treatment with medications may also require admission to a special care nursery like a NICU for cardio or respiratory monitoring and observation. So just for sake of time, we're not going to go in grave detail regarding the specific types of drugs used, but you can always refer back to this slide if need be. So just to kind of recap everything we've talked about as far as the interventions and treatments, the one approach that seems to be a common theme is the Eat, Sleep, Console, which is the ESC approach. And this has been developed to focus on the comfort and care of these infants by maximizing the non-pharmacological methods, increasing family involvement in treatment of their infants, and then utilizing the pharmacological treatment as needed. So specifically, this model looks at the eating pattern for the baby. So is the baby feeding normally? It also looks at the sleeping patterns. Is the baby able to fall asleep? And then the consoling. So can the baby be consoled within X amount of time of crying? So again, just kind of recapping, it actively involves and empowers mom and baby so that they're both reaping the benefits. As well as this approach has been proven to show it's significantly less likely to receive a drug treatment. And then it also reduces hospital stays by more than 2 weeks.
So in terms of future interventions and treatments, from the empirical research that we were reading, there's definitely a need for more long-term studies. That was one of the things that was lacking the most. We definitely know how to alleviate symptoms at the time, but we don't know as much about what happens with the babies as they develop and which methods work better or worse in terms of long-term. Future interventions will also include maybe more of a focus on maternal and infant dyad. This includes adopting a comprehensive model of care that would include more sex-specific approaches to medical and mental health care, more individual and group addiction treatment for mothers, and providing more advanced skills for development of mothering, nutrition, and regaining self-worth, as well as providing more appropriate neonatal care to mothers and parents. Community-based treatment facilities that have incorporated these comprehensive programs, they have been really successful. 73% of mothers remain drug-free of all opioids for 3 months after completion of these residential treatment with this type of program. And similar models, if we were talking about the costs earlier, similar models have also been reported to be cost-effective.
All right, so then finally here we have some resources for you all. We have both local and national resources, so if you're interested at looking within the Arizona area for mothers and babies battling this addiction and withdrawal, as well as on the national level. So if you're interested and want to look more into it, we've definitely provided some good resources here for knowledge and for practice and counselors, etc. So please take a look if you are interested in that. Here are our references, and that is all. Thank you so much.